Okay, and good morning and welcome to the Davies Use Case webinar being presented by VCU on reducing CAUTIs. This is a Davies award-winning use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety here at HIMSS. It is my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support, best practice guidance, access to clinical data to analyze progress, and information and technology enable patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speaker for today, Shelley Knowlson from VCU. Shelley, I'll turn the presentation over to you and begin when you are ready.
Good morning. My name is Shelley Knowlson. I'm a clinical nurse specialist currently working in the infection prevention role. I'm excited to share with you today the collaborative work between the infection prevention and information technology departments and demonstrate how through continuous process improvements we've become a top-performing organization in reducing our catheter-associated urinary tract infections, or CAUTI. And it's not forwarding for me for some reason. Oh, there we go. Here is an outline of our case study. I'll explain to you why we focused on CAUTI, highlight a number of our interventions that we implemented, and discuss the impact that those interventions had, and lastly, the lessons that we learned along the way. So why was catheter-associated urinary tract infection reduction a focus for our organization? Most CAUTIs are due to unnecessary catheterization. Not only are they commonly placed unnecessarily, but they're often left in place longer than is needed. Bacteria found in the urine of catheterized patients often leads to unnecessary antimicrobial use, which contributes to secondary issues such as C. difficile infections. The urine of patients with indwelling catheters is a major source of antibiotic-resistant organisms. And because CAUTIs are considered preventable events, they were one of the first hospital-acquired infections selected for non-payment by Medicare. In 2016, the U.S. Department of Health and Human Services set a national goal to decrease CAUTIs 25% by 2020. The economic burden for catheter-associated UTIs is difficult to assign a number value to. In 2009, the CDC placed the overall national cost of CAUTIs at $340 million per year, and their recent estimates put the cost at $1,000 per event. However, in February of this year, a published systematic review found that current estimates of $1,000 per event is actually an underestimate and an oversimplification of the true economic burden, especially when you consider that CAUTI is the leading contributor to secondary bloodstream infections, or BSIs. The study estimated that the aggregate national burden of cost secondary to CAUTI is actually closer to $1.7 billion per year. And this value seems to be in close alignment with the AHRQ's 2017 published meta-analysis that estimates the cost per event is actually closer to $14,000. Regardless of dollar value, the fact is that the hospital does not receive any reimbursement dollars related to catheter-associated UTIs, making this a costly event for both the patient and the organization. So we'll talk first about our baseline data. So 2012 is the year prior to a lot of our targeted utilization of IT. that we use to aid in our efforts to reduce catheter-associated UTIs. Here, the ICUs have the largest number of urinary catheters, and as a result, the greatest percentage of CAUTI. In 2012, the adult ICUs had 74 catheter-associated UTIs, which was 68% of all device-associated HAIs, and the CAUTI rate was 3.1 per 1,000 device days. So while we were working to reduce all of our HAIs, catheter-associated UTIs was a main focus when you consider the financial impact to the institution as well as on the patient morbidity and mortality. Our organization would not have been able to be as successful as we are at reducing HAIs without the aid and support of our IT department. Due to the number of IT-related quality and process improvement projects aimed at reducing hospital-acquired infections, our organization recognized the value of having a dedicated IT liaison position to work within the infection prevention department and approved a full-time position. This has really solidified the working partnership between our two departments and helped to streamline most of our IT process improvement projects. Our organization has an interprofessional shared governance committee, the IDTC, which is designed to review proposed changes to and make suggestions to improve the electronic medical record. A number of our interventions that we'll be outlining today came through this committee, and 2 of our infection prevention nurses also sit as members of this committee. We also have an enterprise analytics team that has really helped us obtain accurate, timely, and consistent data to drive improvement projects and help the infection prevention team with surveillance through the reports that they create for us. Here is the overall timeline of collaborative initiatives between IT and infection prevention. We're going to be talking about each one of these projects and how they impacted our CAUTI rates. This view is really more to point out the fact that we've been on a constant and ever-evolving journey as an organization to make our tools better and create new ways to help meet our CAUTI reduction goals. Our first step to CAUTI reduction was to perform a systematic and rigorous review of the evidence to determine the best practices for reducing catheter-associated UTIs. The term bundle in regards to infection prevention represents a combination of multiple interventions that, when used together, have been shown to significantly improve outcomes. For CAUTI prevention, the best evidence comes from the CDC HICPAC guidelines, as well as the On the Cusp project from the AHRQ. And so we base our initiatives on their recommendations. And the arrows on the screen highlight the components of the bundle that our partnership with IT helped with our CAUTI reduction. Prior to 2013, IT had already created some really great tools that helped to raise awareness of indwelling catheters as an effort to reduce device days and infections. One of them is the safety dashboard, which is the picture on the top right. This dashboard has been modified a few times since its creation, but at a glance you're able to see who has a catheter, the date the device was inserted, and a running tally of number of days that this device has been in place. The safety dashboard is used by nursing and unit leadership daily to try to identify opportunities to reduce catheter days. IT was able to incorporate the same data and roll it into a health system electronic handoff form for providers, which is the screenshot on the bottom left. And again, it has the same device days and when it was inserted and where they're located. So just another tool to raise awareness of our catheters. In 2013, we did a rigorous overhaul of our indwelling urinary catheter policy. We outlined appropriate criteria for catheter insertion and continuation. It also included an intermittent catheterization algorithm to be used once a catheter was removed, and included a nurse-driven protocol that allowed for independent removal of the catheter. The policy also required the nurses to perform a daily assessment of the catheter and document if the catheter met the approved criteria for continued use. We partnered with IT to help create fields within iView for nurses to document this daily review for necessity. Conditional logic was used, so if a nurse selected that the criteria was not met, a required field would pop up and the nurse had to document what action was taken, and that's what's on the screenshot that you see on the slide. So the conditional logic, they had to select that they either removed the catheter or they notified the provider. IT worked with the bedside nurses within the IDTC committee to determine where best this EMR documentation should exist. And since it's part of the nurse's daily assessment, it was a logical decision to add these fields into the iView indwelling catheter band, which is part of the daily assessment fields for the nurses. We wanted to be able to evaluate the compliance with daily nurse documentation for necessity. To do this, we utilized an enterprise analytics report created by our IT partners. This report has been and continues to be an invaluable tool in the daily surveillance work of the infection prevention team. The top picture is a snapshot of the daily device day report that was created. And we use this report to obtain and track accurate number of device days. The report is automated to generate every day and is sent to the infection prevention nurses as well as to unit nurse leaders. And so we use this report to perform monthly point prevalence evaluation of compliance with the daily documentation of need. For point prevalence survey, we pick 1 or 2 days in the month and evaluate all patients with indwelling urinary catheters on those days and evaluate for compliance with their documentation. The graph at the bottom represents the trend in our compliance with the daily assessment since we started in 2014. And you can see we've had a consistent improvement over the last 4 years, and last year we are at 97% overall for compliance in this metric. The compliance data is also reported monthly in our infection control committee and summarized in our annual report that goes to our board. The infection prevention nurse also uses this data to give monthly feedback to their units if there is a decrease in their compliance. One of the lessons we learned is that while having the nurses document the rationale for indwelling catheters helped raise awareness, it did nothing to prevent them from initially being placed. To do so, we had to engage our providers. We did this by first requiring them to place an order for insertion, and second, by documenting the same rationale that we had already asked the nurses to assess for. The infection prevention department collaborated with our IT colleagues to have provider order entry created. In the screenshot, you can see that conditional logic fields were created for providers, including approved indications. Lastly, IT added detailed comment that further empowered independent nurse removal of the catheter. We learned through feedback of our nursing units was that despite having a nurse-driven protocol added to the policy in 2013, there were some questions if they could really remove a catheter without asking for permission first. This detailed comment really ended any debate in that regard. IT was instrumental in creating job aids for this process change. Information was shared through different venues, including email and net presenter notifications. And there was also concurrent education with our nursing staff to ensure that provider order entry was present for a urinary catheter. The second part of this process change was IT's creation of an automated removal order. Timely removal of urinary catheters is important because for each day a catheter is left in place, the patient has a 3 to 7% increased risk of acquiring a catheter-associated UTI. The order to remove the catheter 72 hours after insertion was generated off of the iView Foley catheter dynamic band that the nurse creates either on admission or after insertion. And this was really a thoughtful way to generate the order, as it ensured that the removal order would be created even if there was no order for insertion of the catheter. So this would help to capture those patients who had a urinary catheter already present on admission, either from another organization, from the ED, or potentially from the OR. There were also provider alerts generated into the order entry. 24 hours after insertion, providers get this alert, and they have 3 options to choose from. One is they could choose to have the catheter removed now. Another is they could remove the catheter as ordered at the 72-hour mark, or they could choose to continue the catheter beyond 72 hours if they knew this was going to be a longer-term need. This is a great reminder to our providers that their patients have an indwelling catheter in place. If a removal order isn't entered, then the provider will get an alert every 24 hours until they enter an indication or continuation order. The screenshot shows how the providers have to enter an indication for continuation. To try to minimize some of the alert fatigue, IT built a stop to the alerts if the provider enters that the catheter was related to a chronic need or potentially an end-of-life situation. So it kind of helps minimize unnecessary alerts. Finally, they have to enter a new removal time frame or a date that's specified when they're putting in the continuation order. This was really a complex design, and there was a lot of testing involved, so IT worked with a group of end users and providers to make sure that there was adjustments to order entry process to try to achieve our goals without making the process too burdensome on the providers. The original 2013 intermittent catheterization algorithm directed nurses to notify providers after a single high bladder scan finding. So this screenshot shows how they have to enter an indication for continuation and try to help with the alert fatigue. IT built a stop to the alerts firing if the provider selected that the reason for the continuation was for a chronic need or end-of-life situation. Also, the providers have to enter a new removal time frame or a specified date when they're putting in the continuation. This was really a complex design to build the order entry, and there was a lot of testing involved. IT worked with a group of providers to make sure there was adjustments to the order entry process to help achieve our goals without making the process too burdensome on the end user. The original 2013 intermittent catheterization algorithm directed nurses to notify providers after a single high bladder scan finding. What we found through feedback from our nursing staff is that when the nurse would approach a provider about a single high residual, more likely than not they would be directed to reinsert the indwelling urinary catheter. A group of nurses from the Critical Care Practice Council performed an evidence-based review for best practice in terms of timing and frequency of intermittent catheterization to determine when it was appropriate for a new catheter to be inserted. Based on the findings from the review, a new intermittent catheterization algorithm was created and the hospital policy was amended. The nurses really liked having reference information hyperlinked into Cerner, so we asked IT to have the new algorithm hyperlinked into iView under the urinary catheter band. And so once again, the end user has access to the updated policy and algorithm without having to leave Cerner. Current evidence supports the reduction of falsely reported CAUTIs by decreasing the number of urine tests that are being ordered. In part, this is because after a few days, the catheter biofilm becomes colonized with patient bacteria. Per CDC criteria, a positive culture plus a fever equals a catheter-associated UTI. However, in most cases, this positive culture represents simple colonization rather than true infection, meaning the fever may be falsely attributed to the urine when actually there's an alternative explanation. Most ICU urine tests are ordered as part of a fever workup that is based on a pan-culture mentality, where blood, urine, and sputum are ordered together, often indiscriminately. Most patients have an alternative reason for fever, and the risk of developing serious complications from a urinary tract infection are usually minimal. With this in mind, the infection prevention team brought urine test stewardship evidence to the Critical Care Committee, and together we agreed upon working towards reducing urine culture testing by 20% in 2018. One of the ways we attempted to reduce testing as part of the fever workup was to modify the UA reflex culture that is one of the elements in the ICU pan-culture power orders. We worked in partnership with IT to have the urine culture removed as a pre-selected item. And here's where having a good working relationship with IT was really paid off. The analyst who was working on this suggested that we embed reference text into the power order so the providers can see who the appropriate patient population is for testing. And that's the green section that you see on the slide. Note that we did not eliminate the opportunity for providers to order the test. We simply hope that by forcing a conscious decision to order a UA with reflex would reduce indiscriminate testing. To be able to track our progress on our goal to reduce urine tests in the ICU, we again reached out to our IT partners. They created for us a monthly enterprise analytics report that captures the number of urine tests per month per ICU. This has allowed us to track and report back to the ICUs timely and accurate progress every month. We have asked for a few modifications to the report along the way as we noticed there were additional ways that providers were ordering tests. But this dashboard is an example of the scorecard that we're able to send out every month as a result of those reports. The journey to find ways to stay ahead of the curve never ends, and here's a couple of projects that are currently being developed by our IT colleagues. So one of the lessons that we learned with the urine culture stewardship is we recognized there were a number of different ways that providers can enter an order for a urine culture. Not everybody uses the ICU pan culture power orders. For example, they can save orders to a favorites folder within Cerner, or they can type in the word urine when they're adding a lab test. Also, the issue of inappropriate urine testing is not isolated to adult ICUs. And we found that the most efficient way to remind providers not to test is to utilize the EMR decision support during order entry. And so IT is currently building order entry decision support for our urine cultures, which is what you see on the screen. This is just their first take of that order entry. We've had similar success with reducing our C. difficile rates with EMR decision support, and so we're hoping to mimic that success with our urine testing. During a recent infection prevention point prevalence evaluation, we found that there were urinary catheters being left in place beyond that 72-hour removal order with no continuation order. So we asked for feedback from our bedside nurses to figure out why they felt like this was happening. And they felt that because the order to remove the catheter is generated 72 hours before the actual task to remove the catheter, the order kind of gets lost within the EMR. So we wanted to see if we could leverage Care Compass to send a reminder to the nurses when that 72-hour removal order is due. We brought the results of the point prevalence evaluation and the evidence to our IDTC Council, and they approved to have a task fired to remove the catheter at the 72-hour mark on the nurse's Care Compass. Within the IDTC, there was a lot of conversation about when this task would fire on Care Compass, and instead of it being generated at that exact 72-hour mark, what they felt would be most helpful is for the task to generate during the morning hour, so around 9 or 10, so that it would have a heightened sense of awareness for provider rounds, so there could be a meaningful conversation about the catheter use at that time. So I don't have anything to share on what that looks like, but that is currently in development. All right, results. So this is an evaluation of our automated 72-hour removal intervention. Here we're looking at our utilization ratio, which is how many catheter days we had compared to our expected number of catheter days. And I know this looks confusing, but I promise I'm going to make sense of it all. First, I want to explain the standardized benchmark means that we are risk adjusted and compared to other hospitals of similar size and patient complexity. And I want you to pay attention now to the dotted line that goes across the slide horizontally. This represents the CDC benchmark of 1. Anything above this benchmark of 1 means that we are performing worse than expected, or in this case, we have more catheter days than would be expected. Anything below the line indicates that we are performing better than expected for a hospital of our size and complexity. So the goal is to be below that benchmark of 1. The vertical yellow line is where we implemented the automated removal orders. Before the intervention, we had more urinary catheter days expected, and after the automated removal orders, you can see that we are outperforming expectations. After our intervention, we actually prevented over 5,000 catheter days, and on average decreased almost 200 catheter days per month. And this is huge when you consider that the risk of infection increases 3 to 7% per catheter day. We then wanted to see if the automated removal order had an impact on our CAUTI rate. And a CAUTI rate is the number of infections per 1,000 device days. So for this, we compared the infection rate 15 months prior to and the intervention and 15 months after. And what we found was there was a statistically significant reduction in our CAUTI rate after we implemented the automated removal order. And our rate dropped from 1.3 to 0.8, and our standardized infection ratio went from 0.77 to 0.47. Here's comparing, again, our baseline in our adult ICUs in 2012 to last year, 2017. We went from 74 urinary tract infections in 2012, and last year we had 24 in our adult ICUs. So that's a 61% reduction in our CAUTI rate, which went from 3.1 to 1.2 per 1,000 device days. I should note that there was 2 definition changes. 2015, the CDC changed urinary tract infections definitions to exclude yeast and candida. However, when you're talking about the SIR, or standardized infection ratio, you're still comparing expected over observed. And then you can see the ventilator, the green piece of the pie in 2012 as compared to 2017. There was a definition in ventilator-associated pneumonias. Now they're classified as ventilator-associated events, and so it's capturing a whole lot of vent changes that are not necessarily infectious. So that's the reason for the big change in that ventilator portion. This is our CAUTI rates for our whole organization since our interventions. And we had a 57% in our CAUTI rate for our organization during this time frame. This is our standardized infection ratio, or SIR. This is the risk-adjusted ratio of the expected number of infections compared to our actual number of infections. And as with our utilization ratio we reviewed earlier, 1 is the benchmark. So anything above 1 means that you are performing worse than expected. Anything below means that you are outperforming. And if you look at starting in 2015, you can see that's when we initiated our automated removal orders. We are consistently outperforming what would be expected for our catheter-associated UTIs. In fact, we prevented, when you compare your expected to your observed, we prevented over 109 catheter-associated UTIs. Even though this is a fairly new initiative, we wanted to see if the change we made to our ICU pan culture order made an impact on our testing fidelity. And for testing fidelity, we're looking to see if tests were being ordered for appropriate patient populations most likely to be at risk for an invasive infection related to a UTI. So we looked at the fidelity 3 months prior to the order change and 3 months after, and again we found a statistically significant improvement in test fidelity after the change in our ICU pan culture power orders. This is our monthly dashboard for June, and you can see that we continue to trend down on our average number of urine cultures per 100 catheter days, and we are closer, pretty close to our 20% reduction goal of 15.7. All right. So we are currently a top 10 Vizient performer for CAUTI. We're very excited to have reached the top decile in this metric as an organization and really believe that our IT focus on interventions has really helped us to achieve this goal. Since 2012, we have reduced our infections or catheter-associated infections in our ICU by 61% and 50% in our non-ICUs. Since 2015, we have reduced our catheter days by over 5,000. We've prevented over 100 urinary tract infections. And earlier we gave the statistic of 36 deaths per 1,000 infections. And so using this calculation, we likely prevented approximately or at least 4 deaths attributed to CAUTI. Depending on the dollar value you would assign to catheter-associated UTIs, we have saved as an organization $1.5 million. And we have reduced over 200 bed days, and our average length of stay for our organization is 6 days. So by reducing bed days, we've afforded an additional 35 to 70 hospital admissions. This is huge since our organization operates at greater than 95% capacity, so freeing up bed space is significant for our organization and our patients who need our services and who may have otherwise been delayed in being admitted. We've started, so what did we learn? We started our interventions with our nurse documentation for need rather than having both nursing and providers together looking at indications for catheter use. So you want to make sure that you engage all of your stakeholders together at the same time and get everybody on board from the start. We also found that we had a significant impact on our rates when we implemented the automated removal orders. So if we were going to do this over again, we would want to start out with leveraging IT to reduce CAUTI and make the automated urinary catheter removal orders as the top priority. Using consistent and reliable data to drive QI projects is invaluable as it allows us to give timely feedback, reduce manpower of manual audits, and the ability to repeat process analysis consistently over time. I honestly cannot say enough about how important our enterprise analytics reports are for our infection prevention department. Also, feedback from end users is important in determining what makes their job easier, whether it's less clicks or embedding policies so they don't have to hunt for information. And we learned that with proper communication and job aids, you can be successful at making large changes to the EMR and roll all of your changes out at one time with minimal impact to the end user. We've demonstrated that EMR decision support contributes significant impact on results, especially in a large organization where dissemination of information and standardization across service lines can be challenging. Leveraging IT truly extends the reach of the infection prevention team and supports the hospital's safety goals in a way that no email or single person's effort at communication could ever hope to accomplish. The IT tools have put into place it's like putting an infection prevention person at every bedside to help guide decision-making and to aid in our hospital-associated infection reduction program. Thank you very much. And that would be it.
Well, thank you, Shelley. Thank you for joining us today, and thank you for being flexible on our technical glitches. Sorry about that. And we want to remind folks where to go find this great presentation and other valuable Davies use case recordings. And that information can be found at the Davies website at hims.org/Davies. You can find that information and information on how to apply for Davies. Again, thank you very much for joining us today, and have a good rest of your day.
You too. Thank you.